Hello and welcome. We are going to talk about sciatica, proximal and distal blocks, mainly about the distal block as being proposed by me in the form of Gore's sign. We have been going through immense literature about sciatica causation and pathophysiology, and what we have found is one of the most important papers is the paper in Spine 2004, written by Shen et al. Now this is the paper where we talk about effect of nucleus pulposus on the nerve root activity, mechanosensitivity, axonal morphology, and sodium channel expression. So there are four things which are being talked about. And what is found is 7 days of exposure of the nerve root to the nucleus pulposus gives a potential neural conduction block, higher intensity of ectopic discharges on compression due to mechanical sensitization of the root, whereas 6 weeks of exposure resulted in desensitization of the nerve root. Going further, it is proposed that numbness is loss of neural activity propagated to the central nervous system. Intense pain and paresthesia are because of higher ectopic discharge rate. More severe symptoms clinically during the acute stage of disc herniation are seen. An abnormal accumulation of sodium channels at the tip of injured axons increases the conductance of voltage-gated sodium channels. And this is one of the important basis of sciatic pain, and therefore we feel that use of sodium channel blockers could be one of the important ways of treating the pain. Now, increased conductance gives lower voltage threshold than pressure threshold, and neurons therefore give ectopic discharges. Hyperexcitability gives spontaneous and moment-evoked neuropathic paresthesias, dysesthesias, and pain. This moment-evoked neuropathic pain can be also seen as straight leg raising related pain in many of our patients, even though the nerve may not be under mechanical compression. The clinical relevance of this study is the nerve roots become sensitive to mechanical compression 7 days after exposure to nucleus pulposus. Mechanical stimulation to the nerve root can provoke abnormal neural activity that can manifest as pain and paresthesia, and mechanical stimulation includes compression from the herniated disc or stretching of the nerve root, as in straight leg raising test. Now, this stretching of the root in the minimum form is seen more as pain going down the leg when the patient sits with the legs crossed, as we Indians sit on the floor with the legs crossed together, and there it manifests more as inability to sit for more than few minutes because the nerve becomes much more painful than what it is otherwise. This study which we are trying to do now is primarily addressing the point that where is the pain coming in sciatica. It is basically inflamed and mechanically stretched nerve root. It is a response of the nervous system to the changes of disc degeneration, of annular tear and nuclear fragmentation. And important point is these questions have not been answered in the Kirkcaldy-Willis degenerative cascade, and we don't believe that nerves are silent bystanders in initial stages of development of back pain because of degeneration. Now, the purpose of the study is to understand sciatica and its stages, and we are also noting the intensity and the location of the pain. Sciatica is to be proposed to be staged based on its mechanism of development or time-wise evolution and intensity. So it could be because of inflammation or mechanical compression, and additionally loss of function could be present. And subsets are based on location of the pain, that is the knee pain and the heel pain are proposed to be the subsets of sciatica, and the stages are based on stage of inflammation with mechanical sensitization, then the compression, and then the loss of function as a progression of involvement of the sciatic nerve root. Here we are quoting our study where 70 consecutive patients were recruited with acute less than 3 to 6 weeks of sciatica in various stages of development, early, late, and resolving sciatica, and they also included 10 patients who were operated endoscopically who had some pain which had not totally resolved. Routine focused examination and palpation of the sciatic nerve was done, and use of distal block was done at the ankle. Now we know that the pain normally is diagnosed based on its dermatomal distribution, and this picture shows the distribution in case of L3, L4, L5 and S1 radicular involvement, with the areas of pain which are the core areas of pain demarcated with a dull black shading. The lateral border of the foot commonly is involved with S1, the medial border and the big toe with L5, the shin and the medial aspect of the knee with L4, and front of the thigh and medial aspect of the thigh with L3. Now L5 also involves the lateral aspect of the thigh, S1 also involves the buttock part of the pain and the sacroiliac area of the pain. Now these diagnoses based on dermatomes is okay, but dermatomes are old, they are more than 120 years old, and dermatomal diagnosis may be inaccurate because the dermatomes also overlap. So here we are proposing that we palpate the nerve, and we have found that this spot, which is shown here with a red circle, is where the nerve is extremely tender in case of L5 nerve root affection. This part is called a lateral terminal branch of deep peroneal nerve, and this muscle is the extensor digitorum brevis muscle, which covers the roof of the sinus tarsi, as seen in the right foot here with an image which we have taken from the Nater's Atlas of Anatomy, which shows the image. And here is the roof of the sinus tarsi, which is the tunnel between the talus and the calcaneus on the lateral anterolateral part of the ankle. What we have done is we have used 2% plain lignocaine for a distal block at the sinus tarsi over the lateral branch of deep peroneal nerve, and the sural nerve, which is supposed to represent the S1, was injected around on the lateral wall of calcaneus. And what we did is we saw the partial or the total response which was seen in patients, and the follow-up of this was maintained up to a month or so. Patients were investigated with imaging if necessary, and imaging findings were correlated with the symptoms, and if there was a lack of correlation, that was noted. The results were the nerve was tender in all patients with acute sciatica of L5 or S1 distribution at the time frame of 3 to 6 weeks. Every patient had a positive change in the clinical status with the injection distally. All post-op patients had a full resolution of nerve tenderness by 6 weeks. Flare-ups were correlated very well with the recurrent symptoms. That is, if the patient had recurrent pain, it was well correlated with the flare-up of the tenderness of the nerve. And the staging then was based on total relief of pain, partial relief with or without improvement in SLR, and partial or no relief with the neurodeficit, and subsets based on initial location of partial sciatica but tender nerve and full relief of pain with distal block. We propose that sciatica now can be staged in 3 stages. Stage 1 is where the nerve is sensitized. This is seen in about 80% of our patients who come to us in the outpatient. The nerve is severely tender. The straight leg raising is negative. There is no significant sensory or motor loss. Imaging studies may be negative. Full relief of pain on distal block is seen, and if there is a partial sensory or motor loss, it is relieved by this injection. Stage 2 is a stage of mechanical compression, which we see in about 15% of the patients. There is a moderate nerve tenderness. There is a positive SLR. 6% of them had relief of pain with increased range of SLR after the distal block. The rest of them also had full relief of pain, and images may be positive that may or may not correlate well with the symptom. The stage 3 is in state of nerve dysfunction where the nerve is desensitized. This is seen in about 5% of the patients. There is a neurodeficit. The SLR stretch may be positive, and changes after distal block like relief of tingling and or total reversal of motor deficit is seen in some patients. Images generally correlate well with the staging of sciatica. The significance of staging is it helps in treatment planning. Chemical sciatica can be clinically monitored well now and can be treated. An inflammation part of the sciatica can be blocked by use of sodium channel distally. Probably best response to non-operative conservation, where natural resolution alone can relieve the pain, is detected by our staging and the distal block. Now stage 3 we have seen is a stage of desensitization of the nerve, which correlates very well with the neural dysfunction. Generally stage 2 and stage 3 are the patients, about 20% of our patients, who need some intervention, and about half of them may need a surgical intervention to correct the structural defect which is causing the problem. Now outcome of discogenic sciatica and pain generators is, it depends on the time frame and the level of cytokines. If there is nuclear absorption, annular healing and decreased periradical inflammation, it can go into a positive relief of pain and restoration of function, a very positive result. But in cases where the inflammation continues as a chronic or a subacute inflammation, then the patient may have partial adherence or tethering of the root, persistence of pain, and this could be a negative outcome of sciatica. Now, we also propose a locational subsets of sciatica where knee pain could be a part of L5 related pain, and we feel in our clinical practice that the earliest manifestation of L5 is knee pain on the lateral aspect. It is generally present in spots or over limited area along the lateral aspect of the knee. There is an inability to flex the knee fully in these patients. There is an associated tingling numbness on sitting cross-legged. Pain increases with walking and then radiates along the calf and the lower leg. There is a stiffness at the knee, and there is an urge to extend the knee after sitting for a few minutes with the legs crossed. The knee is stiff in the morning for a few minutes after getting up, and there could be a presence of low back pain in these patients. Nerve supply of the knee, by the way, is by 3 branches of common peroneal nerve, mainly on the lateral aspect, giving superior, inferior and recurrent genicular nerve. And common peroneal nerve is the most affected component of the sciatic nerve, which may be tender, and deep peroneal nerve is tender, which responds to a distal block in these patients who have a pain in the lateral aspect of the knee. The heel pain, in these cases, we must exclude trauma and organic local lesions in the heel. When local nociception can be ruled out, nerve-mediated pain is the commonest. In short, actually we say that if there is no cause for trauma, infection and ischemia, then the pain must be neuralgia. And the pain is well correlated with sural nerve representing the S1. The heel pain in significant numbers follows or precedes back pain, and sural block relieves this pain in the heel. So in short, to summarize, we can detect the inflamed sciatic nerve root. We can relieve the pain at least temporarily by a distal block. We are not proposing distal block as a treatment, but as a diagnostic modality which is very simple and with zero technology.